So let's conclude this very brief section on dysbiotic encephalopathy by saying that intestinal microbes are quantitatively massive and can produce metabolites that bypass the gut, liver, blood-brain barrier to influence brain function. For some of you, that might sound pretty obvious, while for others, and really for all of us, it's still pretty shaking because we as humans like to think of the mind as pure, perhaps even divinely originated. So the idea that intestinal bacteria and other microbes can affect mental function is a bit repugnant, in part because it makes us feel vulnerable and fallible and reminds us of our own mortality. Now let's dive into one of my favorite topics, which is fibromyalgia. The reason that fibromyalgia is one of my favorite topics is because it blends three of my other favorite topics, and those are dysbiosis, mitochondrial dysfunction, and in this case, social injustice. So I'm going to show you that dysbiosis is the cause of fibromyalgia. That leads to a secondary mitochondrial dysfunction. And interestingly enough, when we look at the divergence of basic science with clinical practice, we can also touch upon the concept and topic of social injustice, because I think the medical treatment of fibromyalgia perfectly exemplifies the extent to which the medical profession and medical practice can be easily co-opted, or more specifically hijacked, by the commercial interests of the pharmaceutical industry, despite a mountain of research pointing directly to the cause and cure of this condition. I've been publishing on fibromyalgia since 2008, when I first published a clinical monograph called Musculoskeletal Pain, Expanded Clinical Strategies. This was a continuing medical education monograph commissioned by the Institute for Functional Medicine. In 2012, I published a little handbook called Fibromyalgia in a Nutshell and produced a few videos associated with that. I've also continued to review this material in other publications, as well as in postgraduate presentations that I've delivered throughout North America and also in Europe. So in the focus of this presentation, I would like to clearly establish that dysbiosis accounts completely for all of the major clinical characteristics of fibromyalgia, and that the logical treatment that thereby follows should be the treatment of choice, the standard of care. By so doing, I will by extension establish that the medical analgesic treatment of fibromyalgia is completely misguided. Furthermore, not only is the medical analgesic treatment of fibromyalgia misguided, but by being more expensive, more dangerous, non-curative, and therefore obligatory, meaning that it forces patients to remain dependent on drugs, I think it is therefore unethical. The extent to which the medical profession accepts and uses a treatment protocol that is unnecessarily expensive, dangerous, non-curative, and unethical is proportionate to the extent to which medical practice in this regard is unscientific, misguided, and out of accord with its promulgated goals, which is the welfare of patients. So in order to build the model of fibromyalgia as a dysbiotic disease, I'll review each of the key components listed to the right of this slide, and then I'll start at the bottom of this list with the mechanisms and molecules, and then ascend upward to the clinical implications and proof. Also, necessarily and importantly, I'll spend some time deconstructing the erroneous model that suggests that fibromyalgia is a disorder of primary central sensitization that quote-unquote needs to be medicated with expensive, ineffective, and hazardous drugs. Critical thought and analysis are intellectually vital but socially condemned these days, as critical thought in general and science in particular have become increasingly politicized. In my opinion, true, authentic postgraduate education must not focus solely on incorporating new information. It must also include the critique and excision of erroneous information that has become inaccurately or inappropriately incorporated into the body of knowledge. So as you can see on the right-hand side of this page, I'm going to start with tertiary and supportive criteria showing internal consistency and molecular plausibility. I will then ascend to secondary criteria, evidence of a causative microbial load, which has already been established in these patients. And then we'll conclude with the primary criteria showing that fibromyalgia is indeed responsive to microbial interventions, especially the use of non-absorbable gastrointestinal antibiotics. Again, we need to spend a little time deconstructing what's already been published so many times, because for many of you, especially for those of you who are new to functional medicine, you might not be aware that a lot of the information that's out there, even though it's well accepted, it's not accurate, and it should not be well accepted. It should have been, in my opinion, refuted at the level of the editors if they had had the gumption and the interest to actually present in my opinion, more accurate information. So, as we all learned from science fiction movies, sometimes we have to unlearn what we have learned. And according to Pablo Picasso, every act of creation is at first an act of destruction. So we have to deconstruct the old paradigm and then bring in a new one. I'm sure we're all familiar with this diagram from the 1990 criteria for fibromyalgia. These criteria required the demonstration of at least 11 out of 18 tender points as assessed by a clinician's physical exam. Very unfortunately, even though this was published in the 1990 criteria, in the 2010 criteria, the need for a physical exam was completely excluded. And in fact, the authors stated that they had the intention of excluding the need for a clinician's physical exam. So let's look at those criteria side by side. In 1990, the diagnosis of fibromyalgia required a clinician's judgment and physical exam. In 2010, 20 years later, the diagnosis of fibromyalgia became an easy self-diagnosis that people could do with internet checklists, etc. So the clinician was basically eliminated from the criteria by eliminating the need for a tender point exam. In 1990, the criteria were quite narrow for a very specific diagnosis. In 2010, the criteria became very broad, and the author stated that the problem, quote-unquote problem, was that the previous diagnostic criteria were too limiting and too narrow, too specific. Well, diagnostic criteria for any disease should be narrow and specific. That's what makes a disease a specific disease, not a symptom cluster. So I was suspect when I read that in the original report in 2010, where the author stated that they had the intention specifically to make the criteria more broad. That certainly does not serve patients with this disease because it broadens and makes less meaningful the consideration and our understanding of fibromyalgia. In 1990, patients cured of the disease no longer met criteria, and I think that's very normal and legitimate, whereas in the 2010 criteria, the stated problem that was addressed was that these patients could be cured and they no longer met criteria for the diagnosis. Well, that's not a problem in clinical medicine. When patients are cured, by definition, they should no longer meet criteria for the disease. So the question becomes, for anyone who I think read this article with any amount of diligence, why did the authors specifically dismantle the curability of fibromyalgia, we might say, by making the diagnosis more durable? Who does that serve? It really doesn't serve the patient, in my opinion. So we'll discuss that as we go through. And in 1990, the criteria, in my opinion, were very valid. The goal was to make the diagnosis of fibromyalgia clinically meaningful. In 2010, I think the shift went from validity to profitability. The stated goals by the authors were to make the diagnosis of fibromyalgia easier, broader, and more durable. Again, that does not serve patients. I think it really only serves private and profitable interests. Of very specific note, the 2010 criteria were sponsored, yes indeed, by a drug company. Fibromyalgia is commonly described as a quote-unquote idiopathic syndrome, principally characterized by widespread body pain and numerous myofascial tender points at specific locations, most common in women 20 to 50 years of age, and often presents with other complaints, such as fatigue, migraine headaches, altered sleep patterns, and gastrointestinal disturbance. Again, it's commonly described as being quote-unquote idiopathic, which means we don't know the cause, with strong neuropsychogenic influences. The mainstays of medical treatment are, of course, as you would already guess, perpetual pharmacotherapy and adjunctive use of psychotherapy and limited exercise. What you'll notice very specifically as we go through the pathophysiology of fibromyalgia is that pharmacotherapy, psychotherapy, and limited exercise will absolutely fail to effectively address the legitimate cause of fibromyalgia. Again, these patients commonly have irritable bowel syndrome, migraine headaches, dyscognition, and environmental intolerance, and multiple chemical sensitivity, and I'll show you how all of that overlaps on one of the upcoming pages. We also note that patients with fibromyalgia syndrome, or what I call fibromyalgia disease, frequently have histologic and functional abnormalities in their muscle tissue. They also show consistent mitochondrial defects. They also have secondary coenzyme Q10 deficiency and increased levels of oxidative stress. So, for example, if we just look at these 4 items which have been proven again and again among patients with fibromyalgia, this alone shows you that fibromyalgia cannot be solely due to so-called primary central sensitization. A brain disorder cannot cause these problems. A brain disorder cannot cause problems in the muscle, as well as the mitochondria, as well as secondary inflammatory and oxidative consequences. So we have to be looking at something that is occurring outside of the enclosure of the central nervous system. So let's integrate these 4 factors into our model of fibromyalgia. Again, histologic and functional abnormalities of muscle tissue, mitochondrial defects, coenzyme Q10 deficiency, and oxidative stress, number 4. Moving on now to number 5, we see neuroendocrine abnormalities, low-grade immune activation, of course, bacterial overgrowth in the small bowel, which is, in my opinion, the cause of fibromyalgia. We also commonly see vitamin D deficiency in these patients, and low plasma levels of L-tryptophan. Central sensitization is indeed seen in patients with fibromyalgia, so the most easy way to understand central sensitization is that the brain does become more sensitive to the reception and perception of pain signals. So these patients do feel more pain from stimuli that should otherwise not normally trigger a pain response or a pain perception. So fact number 1, central sensitization is a real neurophysiologic phenomenon whereby the central nervous system develops a low threshold for pain perception, resulting in the sense of pain from stimuli that should not be painful, also called allodynia. The controversy is that many doctors believe or have been led to believe that the pain of fibromyalgia is due to primary central sensitization and that the condition needs to be treated indefinitely with pain-relieving drugs. I think the notion of primary central sensitization as the cause of pain in fibromyalgia is scientifically untenable. I think it's illogical based on the published research. I think it's medically irresponsible because it forces doctors to not treat an otherwise treatable condition. And I also think it's ethically harmful because it fails to maintain the physician's ethical responsibilities to maintain patient autonomy, to provide beneficent care, and to not cause harm. And we'll see that a lot of the drugs that are FDA approved for fibromyalgia are actually quite dangerous in addition to being ineffective. So again, many doctors have been led to believe that the pain of fibromyalgia is due to primary central sensitization and that the condition needs to be treated indefinitely with pain-relieving drugs. Here we see the former president of the American Pain Society. He says, "The problem fundamentally in fibromyalgia is that the ability of the body to sense noxious stimuli has been distorted." And then he gives some vague reasons for this. He says it could be a viral syndrome, it could be trauma, or he says it could come out of the blue without any precipitating event. So for those of you who have studied at least a little bit of the history of medicine, you will probably recall that early medicine was based on magical thinking and spontaneous generation. And here we see magical thinking and spontaneous generation again return to the practice of medicine with the belief or the presumption or the assertion that fibromyalgia could just happen out of the blue without any precipitating event. Let's take a look at some words of wisdom from the American Academy of Family Physicians. This was published in 2007. Again, they conclude that fibromyalgia is an idiopathic chronic pain syndrome characterized by sleep disturbance, fatigue, headache, morning stiffness, paresthesias, and anxiety. Also, depression is quite common among these patients. This article also emphasizes the need to find 11 out of 18 tender points at specific anatomic sites. Of course, that was later overturned in the 2010 criteria. And not surprisingly, the conclusion of this article is that physicians should use a quote-unquote multidimensional approach with patient education, cognitive behavioral therapy, exercise physical therapy, and of course, analgesic pharmacologic therapy. So in order to reach these types of conclusions, a lot of research has to be overlooked. So let's try to recall, as we look at the other data, that this was published in 2007. So let's look at what was published before 2007 that should have resulted in a different conclusion rather than the fact that these patients, quote-unquote, need behavior therapy, psychotherapy, physical therapy, limited exercise, and endless analgesic drug therapy. Moving on now from American Family Physician, let's take a look at Mayo Clinic Proceedings 2011. A lot of the assumptions that were published in the abstract of this article, for example, are completely wrong. namely that fibromyalgia has a neurogenic origin, that it is a disorder of pain processing, and that these patients need pharmacological therapy as the main treatment intervention. You'll see that this article has 3 authors, and you'll also notice that each of these 3 authors has been paid by 3 separate drug companies for their authorship of this article. Pfizer, Forest Labs, and Eli Lilly are the 3 companies that have FDA approval for the 3 drugs for the treatment of fibromyalgia. I'll review each of those drugs with you in just a moment, but let's look at the first 2. We see that Cymbalta has FDA approval for fibromyalgia, and it's produced by Eli Lilly. We also see that Lyrica or pregabalin is also approved for the treatment of fibromyalgia, and it's produced by Pfizer. Speaking of Pfizer, we also notice that the Fibro Collaborative Group, which also helped produce this review, was also sponsored by Pfizer. The Fibro Collaborative is described here as a quote-unquote diverse group of leading experts, all of them, of course, funded by the drug company that makes the drug for this condition. We also see that the quote-unquote editorial support for this article was also sponsored by Pfizer. So even though this article was titled The Science of Fibromyalgia, I think it should have more appropriately been titled The Sales of Fibromyalgia. And as I reviewed previously in video format, I think this is a good example of corporate rationalization advocating pharmaceuticals. Let's take a look now at each of those drugs. Pregabalin was approved in 2007. Its most notorious and infamous adverse effect includes weight gain. Sometimes that can be a weight gain of 20 to 30 pounds very easily. It also comes with a black box warning for increased risk of suicide and depression. You'll notice that pregabalin comes with a monthly cost of approximately $100 to $200 again per month. Following closely in 2008, the FDA approved duloxetine for the treatment of fibromyalgia, goes by the trade name of Cymbalta. It also comes with a black box warning for increased risk of depression and suicide. We also note that the monthly cost for duloxetine at the 60 milligram per day dose is approximately $170. So $170 per month for this treatment. A lot of these patients are treated with more than one drug, and you'll see that each of these drugs costs about $100 to $200 per month. So let's just average that out and say that the typical fibromyalgia patient who's taking 2 drugs might be spending about $300, maybe $400 per month for the analgesic treatment of their condition. The third drug approved for the treatment of fibromyalgia is milnacipran. This was approved in 2009. Let's look at some of its adverse effects. Seizures, suicidality, depression, Stevens-Johnson syndrome, which is a medical emergency, of course, because it can be fatal. Serotonin syndrome can also be fatal. Neuroleptic malignant syndrome, hypertensive crisis, hyponatremia, glaucoma, and liver toxicity. And as you can see at the bottom, milnacipran also comes with a black box warning. Typical cost for this is about $144 per month. An article published in 2013 showed that the drugs used to treat fibromyalgia are just as likely to harm as to help. Among fibromyalgia patients taking either of 2 commonly prescribed drugs to reduce pain, 22% report substantial improvement, while 21% had to quit the regimen due to unpleasant side effects. These drugs receive an enormous amount of advertising, even though the clinical improvement is really minimal. The authors state that treatment with drugs alone should be discouraged, and that chasing a cure of fibromyalgia with analgesic medicines alone doesn't seem to work. Well, of course it doesn't work, because these patients do not have an analgesic drug deficiency. In my opinion, they have secondary central sensitization, and they have secondary mitochondrial impairment due to the small intestine bacterial overgrowth, and I think we should be focusing on those more proximate causes of the condition, and that's what I'll review with you here. So in order to establish fibromyalgia as a dysbiotic disease, the best evidence would be, of course, if we can show that it responds to microbial manipulation, whether that's adding good bacteria or subtracting an overgrowth of bad bacteria, for example. We would also like to see evidence of a causative microbial load. And thirdly, we would like to see some supportive evidence, some internal consistency, and molecular plausibility. And I think we have plenty of all of those. So let's take a look at some of that information now. First of all, we see that fibromyalgia commonly overlaps with other dysbiosis-triggered or dysbiosis-associated conditions such as irritable bowel syndrome, now strongly attributed to small intestine bacterial overgrowth. Likewise, chronic fatigue syndrome also associated with a specific type of gastrointestinal dysbiosis. Migraine headaches commonly have both a microbial component as well, of course, a primary mitochondrial component. Multiple chemical sensitivity also associated with both irritable bowel syndrome, fibromyalgia, and chronic fatigue syndrome. And interstitial cystitis is another disorder associated with central sensitization, where patients become hypersensitive, or we might even say hyperreceptive to pain signals. Again, here, this article emphasizes the overlap between chronic fatigue syndrome, fibromyalgia, multiple chemical sensitivities, and we can look at some of that information here. Let's focus on one of the last quotes, where the authors point out that out of a sample of 100 patients with multiple chemical sensitivity, 88% met criteria for chronic fatigue syndrome, and 49% met criteria for fibromyalgia. This article, published in Frontiers in Neuroscience in 2012, also shows a link or an overlap between several conditions and interstitial cystitis. We see a connection between interstitial cystitis, irritable bowel syndrome, severe chronic fatigue, otherwise known as chronic fatigue syndrome, chronic generalized pain, otherwise known as fibromyalgia, and migraine headaches. So rather than seeing each of these as a separate entity, let's try to connect the dots and see if we can see an interrelationship or an interconnection between these conditions. So we could ask a very simple question. What is the one molecule that can produce each of these superficially different conditions, problems, and its components? For example, pain, central sensitization, inflammation, immune activation, leaky gut, impaired detoxification that would ultimately lead to multiple chemical sensitivity, and mitochondrial dysfunction. Do we have one molecule that can cause each of those components of these other conditions? And I think you'll agree with me that the answer is yes. Bacterial endotoxin, lipopolysaccharide, can certainly contribute to pain, central sensitization, inflammation, immune activation, leaky gut, impaired detoxification, and mitochondrial dysfunction. In Arthritis and Rheumatism in 1998, this article was published showing that patients with fibromyalgia show evidence of impaired mitochondrial bioenergetics, as we used to call it. And in this study, patients with fibromyalgia were shown to have low levels of phosphocreatine and ATP. And the conclusion of the study is that magnetic resonance spectroscopy provides objective evidence for metabolic abnormalities consistent with weakness and fatigue, and they should have also said pain, in patients with fibromyalgia. In this article from American Journal of Medical Sciences, also published in 1998, the authors write, "The presence of numerous abnormalities in fibromyalgia muscle structure and biochemistry have been established by the work of many investigators. In my opinion, this information, this reality, has never ceased to exist. Rather, it has simply been buried by the avalanche of drug-sponsored articles promoting the central sensitization model and the corresponding quote-unquote need and quote-unquote rightness of endless analgesic drug treatment." Again, in patients with fibromyalgia, we see very clear evidence of mitochondrial dysfunction. So any model, any treatment protocol for fibromyalgia must, if it's going to be scientifically valid, must include addressing the mitochondrial component. However, if all we do is address the mitochondrial component, then we're basically blaming the mitochondria for fibromyalgia. If we blame the mitochondria for fibromyalgia, then we're basically stating that these patients have a primary mitochondrial defect that causes their disease. Again, we have to appreciate the difference between a primary attribution versus a secondary attribution. A primary attribution is to say that the condition begins at this step. So if we say that fibromyalgia is a disorder of primary mitochondrial dysfunction, then we're saying the disorder begins with mitochondrial dysfunction. And I don't believe that that's true. These patients do have mitochondrial dysfunction, but in my opinion, the evidence shows quite clearly that this can be a result of the small intestine bacterial overgrowth. So, for example, in this very excellent article published by Cordero's group here in Spain, we see evidence of mitochondrial dysfunction and mitophagy in patients with fibromyalgia. Now, these patients commonly show coenzyme Q10 deficiency, and they commonly respond to CoQ10 supplementation. So again, we have